So congratulations for being and holding the new post at AIOC. We welcome the president of AIOS to speak on Phaco Dynamics now.
इसका projection करो. So, good afternoon, friends. It is a very basic level of course because many of us buy the machine but are not able to use it well. So, I'll be presenting for half an hour the basics of the Phaco machines and Phaco dynamics so that you can utilize them to the optimum. And then you are free to ask any questions about the Phaco dynamics. And then there will be panelists, the moderator Shilpa and Garima will be joining us, and Dr. Anita Sethi will be discussing the various scenario and how to change those parameters. So to have a safe surgery, we need to understand our machine well. So if we talk of the Phaco dynamics, we need to understand the machine. Machine has got a console where all the settings are fed and accordingly it works. Then it has got a foot pedal which gives the command to the console. And then you have got a handpiece in your hand which may be for Phaco emulsification or irrigation and aspiration. And the important part is now actually initially there was a pointer. A pointer there. So the Phaco tip had a bevel which is in the front is 0, 30, 45, 160. So the more the angulation like this will cut better because it's sharper and this will hold better. So but now we have zeroed down to 30 degree. Most of the tips are now 30 degree which works very well. And then there's another very good tip which is called Kelman tip. It is excellent for making a trench because it is angulated downwards. Size of the tip also matters. Initially tip used to have a very wide bore 0.9 mm but it is going down. So the smaller the tip, less will be the surge. But when you are operating a hard cataract, it will get clogged. And when you are operating a very hard cataract, probably you need a bigger tip to have a much stronger hold, and so that it does not get blocked. Most important part which we need to be trained, because all other things you set up in a machine and the staff is doing it, is training of the foot pedal. So whenever you get a machine, a beginner should actually sit down and practice the foot pedal without putting the Phaco probe into the patient's eye, so that he gets familiar when he is in mode 1, mode 2 and mode 3, and how is the audible feedback and the reflex switch we must know. If suddenly you catch something, iris or the capsule, you should know where the reflex is. Another important thing is if you catch something, don't panic, don't move your hand. You hold your capsule, if you don't move, it will not tear. It will cause no general dialysis, no damage will be done. So in fact, in my machine, even I may forget because it rarely happens. I need to reflex, but I written R and the staff knows where the R is. So I tell them to press the R. I may not remember, but when I was learning the Phaco, I will, before starting my Phaco machine, I remind my mind where the reflex is. So before you sit down, even the operating microscope, you should know where the zoom up, zoom down, focus up, focus down. You need to remind your mind before you start operating where the buttons are. So revise in your mind and then start the surgery. And you need to know the side kicks which are very important, like a continuous irrigation mode, bottle height. I mean, there are multimodal functions where you can go from Phaco 1 to Phaco 2. So all these things you should familiarize beforehand and should have a full mental picture of all those buttons, even without using it on a patient. All the settings will depend upon the control and coordination you have. If you have got a good control and coordination, people operate at a 600 vacuum very fast, very quickly. They know whenever they need to deaccelerate, they can accelerate. But if you have got a poor foot control, probably will have to operate at a lower settings. And when you are trenching, while you are coming back, your power should be off. And for this, continuous irrigation mode is very, very important. So that when you are lifting your foot, you don't want a suction to happen. You don't want the energy to be delivered, but you want the fluid to keep on going in. So you may not be able to come to a stage where it is just at between 0 and 1. So if there is a continuous irrigation mode is on, then you lift your foot completely, there is no problem, the chamfer will be maintained. So this is very important. When you are coming back, there should be no energy delivered. when you are chopping, after burning, the power has to be off. Otherwise, the nucleus will loosen around that tip and you will not be able to hold. So once your tip goes inside the nuclear fragment, you should come back into the tube. And if you keep on giving the energy, you won't be able to hold it. And in a Phaco aspiration, when you are trying to suck it, the foot pedal will keep on and off, depending upon when the piece is in front of the tip, you are holding it, you will press it. Then the piece is not there in front of the tip, there is no point of giving the energy. So first the piece has to be held at the tip, and only then you should give the energy, not without. The tip is not around the opening, and then you keep on delivering the energy. And these all measures will reduce effective Phaco time, EPT. So the percentage of energy used and time taken to finish the full surgery is called EPT. So if the machine was used at 100% Phaco energy, how much time you have consumed, in other words. And it's good to have less EPT, but it is more important how you are delivering the energy. That means when you are making a trench, the delivery of the energy is far away from the cornea. It will have no collateral damage if the infusion is not stopped at the top. That means if you lift your hand up like this and the fluid is not going from the top roof, it is compressed, the sleeve or there is a compressed, you will see the wound burn. But if your hand is resting and you are doing a Phaco, your top will not get burned, and the energy used while making trench causes no collateral damage. So don't worry about EPT. Don't worry about if you can't chop. You do divide and conquer, you do a stop and chop, is absolutely as good as long as the patients are happy and you do not cause any corneal damage. And in between you need to give a cooling period. So the basic function of the Phaco machine is the Phaco emulsification, which is done by the power, and then there is the aspiration. When we talk of the aspiration, in other words, the power and fluidics, the fluidics has got two functions, irrigation and aspiration. All this combined we call as a Phaco dynamics. So in the power we need to know how this machine works, how we can modulate it, and what power setting should have. And same in the fluidics, what is the inflow, what are the types of the pumps, flow rate, vacuum rise, followability, hold, compliance, stresses, all these things we need to understand the Phaco dynamics completely. So we know that the power is delivered by the quartz crystal, and the stroke length is usually 2 by 1000 to 6 by 1000. But whenever we say 30% power, actually it may not be the same if you have got a 2 crystal, 4 crystals, 6 crystals. So in a higher end machines, you can keep a very low power, but still it will be very effective. But in an earlier machine with the 2 crystals, you might have to keep a very high power settings. So it is the power which is important, not the percentage which is important. And the most of this fragmentation takes place by the jack hammer action. That's when you hold the piece and bombard it, it gets broken into pieces. But some of it may be because of the cavitation. When the tip goes forward and comes back, there is a vacuum created and the pieces may fall into it. Some of the emulsification may be also because of the acoustic waves which are created by the high vibration of these. So when you talk of the power modulation, there is a continuous mode. Continuous Phaco will have more endothelial damage, more wound burn, and poor holding. So in trenching you can use it, but it's better not to use it in most of the time. Then the burst mode and a pulse mode. Burst mode is rarely used. It's only for a very hard cataract where the density is uniform or using a direct chop. I'll explain you what is the burst mode. And hyperpulse is now in most of the advanced machines, there is a hyperpulse. And now they have got an alternate way of delivering the energy, which is elliptical fashion of the tip movement or the transverse movement of the tip in Alcon and Johnson & Johnson companies. So we talk of the pulse mode is that initially all the machine had a pulse mode. 1 second is 1000 millisecond. If you keep the machine on a 5 pulses is the 50% on time, 50% off time. So total 5 plus 5 is 10. 1000 divided by 10 is 100 milliseconds. Machine will be on, 100 millisecond off, 100 millisecond on, 100 millisecond off. If you keep 5 pulses. If you keep 10 pulses, it will become half. And if you keep say 50 pulses or more, that means 10 times, then 10 millisecond on and 10 millisecond off. So whenever the pulses are more than 50, we call it hyperpulse. So the pulse will be 100, 200. So, but more than 50 is called hyperpulse because there is a more cooling off period between the pulses. The wound burn and the maximum temperature is much lower as compared to the traditional machine. That is the advantage of the hyperpulse because it gives little bit of energy, and before the temperature can go up, it cools off. Little bit of energy and cools off. And then there is another concept of what you call as a duty cycle. Like a person who is working for 8 hours a day, in a 24 hours, his duty cycle is one third. That means one third of the time he is working. Same way, when you give a hyper pulse, initially all the pulse mode were 50 on, 50 off. In a newer machine, it is possible to divide the pulses 67% on, 33% on, 18% on, 24% on. That means this is the, if you keep it at 25%, that means duty is, that person is working 6 hours and 24 hours. So this is the 6 hours is working period and 18 hours is off period. So whenever there is a soft cataract, you don't want so much of energy, you want more cooling period, you can keep the duty cycle at a lower percentage. So whenever you use the hyperpulse, there will be cooling, less shattering, more time for the vacuum buildup also. Because when you are giving energy, the pieces are pushed back. But when you have the only aspiration, there is a suck into the closer to the piece and can grip would be improved. So this is what, when you give a continuous mode, the heat keeps on building. Pulse mode, the equal energy packets which are coming, and there is not that much of cooling. In a hyper pulse, there is lot more cooling period over there. And there is a basic difference in a pulse mode is and a burst mode is. Pulse mode, when you press the foot, the energy will keep on increasing. But in a burst mode, the frequency will keep on increasing. So from when you press down, if it is at the start 0, if you keep it at 50, slowly and slowly as you keep on going down, the energy level will reach at 50. In a burst mode, when you just go at the foot pedal 3 position, there will be one burst coming. As you keep on going down, they will keep on coming faster and faster, but energy level will remain the same. So in a very few cataract, when the cataract density is completely more or less same in a very hard cataract, you can use the burst mode, but by and large, all of us use the pulse mode or linear mode, where we use the energy modulation by our foot. So surgeons are linear mode, where the energy keeps on changing. And the same way, you can keep it on a panel mode, where as soon as you go into foot pedal position 3, what is the preset, that energy will be delivered. We will not go on. So what power setting should be there? Normally we say 25% is the usual power, 2 to 4 crystal machines, 25 plus grade of the cataract. So if this is a grade 5, you need to have a 100% power. If it's a grade 1, you need to have the 40%. And while doing aspiration, you can actually lower the power. EP nucleus, you need 5 to 10%. And that also depends upon the number of the quartz crystal. But you will experience with your own machine what power is right for what type of a setting. And also the power, if your tip is very old, probably you need little more power as compared to when you use the new tip. So now we come to the fluidics. So the basic, there is inflow and outflow. Outflow may be through the wound or through the tip, and through the wound it may be from the main port and a side port, and through the tip it depends upon the compliance of the system, flow rate and a vacuum. So inflow, there is no doubt, it is absolutely gravity fed, depends upon the gravity. Now we have got the pumps which can actively control the fluid, but in most of the machine it directly depends upon the height. So 100 centimeter is approximately 74 millimeter of mercury in the eye. So too much, if you keep the height more than that, normally there will be general stretch and a patient's discomfort. If the IOP is very high, the volume of the fluid in the chamber will not be that much. So the IOP fluctuation will also be more as soon as you suck the fluid. So that may cause iris meiosis and discomfort to the patients and iris prolapse. So safe height is somewhere between 60 to 90 centimeter, maximum 100 centimeter. Keeping at 140, 150 actually serves not much of the purpose, and you unnecessarily increase the IOP inside the eye and discomfort to the patient. So when we talk of the outflow, there are two things. One is the vacuum. Vacuum is the holding power, how strongly it holds. And that depends upon the tip size is very important, because we know the force is area into the vacuum. So if there is an area which is say 0.30. So 3.14, 0.30 into 0.30, total force is 0.28. And if you calculate with the 0.45, it becomes 0.63, more than double. And if you use 0.60, it becomes 1.13. If you use 0.15, it is just 0.07. So the opening at the tip becomes very, very important. That's the reason that when we do the cortical aspiration, which is 0.3, we hardly get any fluctuation because there is not so much of a fluid which is getting drained over there. So the flow rate decides how fast the things will happen. Vacuum decides how strongly you will hold a fragment. So if you have got a preset, suppose 500, so how fast once the tip gets occluded, how fast it will reach to that level. So in other words, it is important that the flow rate, if it is fast, the things will happen very fast and the material sucked into the port will be very good. And then there is a concept of a rise time, that how fast the preset level you will be able to achieve, that depends upon a flow rate. So the venturi pump actually have got a very high flow rate because you can't separate the flow rate from the vacuum. So this is a fraction of the vacuum. So usually 1/3 of the 30% of 1/3. That means if you're operating at a 200 vacuum, so the flow rate may be a 60. Operating at a 400, it may have nearly 100, more than 100 plus flow rate. So that's the reason venturi pump has got a very fast flow rate. So as we know the venturi principle, that the air is passed from the nearby opening and the fluid is sucked into the cassette. So vacuum increases, depending on the vacuum increase or decrease, the flow rate is proportional to that. While on a peristaltic pump, flow is through the flexible silicon tubing. Faster the roller rotate, it is like milking a cow, more fluid will be withdrawn and higher will be the flow rate. So you set up the roller speed on this. So in a peristaltic aspiration system, flow rate decides the followability, vacuum decides the hold, and depending upon the flow rate, you will have a rise time. So there is another concept of followability. So how the pieces will come closer to the tip. So that depends upon the gradient at the tip and the bottle height. So there is a bottle height is there. So there is a eddy current form which is coming towards the tip. So what is the pressure gradient over there? So this is what brings the material over here. In a venturi system, whatever vacuum you set up, it is always at the tip. While in a peristaltic system, the vacuum builds up only when the tip is occluded. That means the followability of the pieces at the tip will be poorer at a peristaltic system. Because it will take, and when you keep very high flow rate, then it works like little bit of like a venturi, but not like a venturi. While in a venturi system, because you have kept a 500 vacuum, so that vacuum is already at the tip, and with the bottle height, so things happen much faster in a venturi system. Then there will be limit for how long this, for how much of a distance it can cover, how many pieces it can fall. So this is the zone of followability, what we are showing you the green. But the pieces which are lying here, if you keep your tip over here, it won't get sucked. It doesn't have that much of power. And the pieces which are lying behind, because there is no followability at all over there. So you will see many a time when you're operating a cataract, a small piece is stuck under the incision or under the side port, because the fluid is leaking from there. It's not coming towards the tip from that side. So while the fluid is leaking, it gets stuck over there and you find it very difficult to bring to the zone of followability. We already talked about it. And that will also depend upon the size of the nuclear pieces. The smaller the pieces, better is the followability. That means when you're holding a nucleus piece, say 1/3 or 1/4, if you crush it mechanically after holding 2-3 pieces, make it 2-3 pieces, then they will follow to the tip very easily. Because one large piece is lying, it won't be able to get sucked. And location of the pieces we already talked. So now we come to the setting of the machine. Most of the now first, second generation machines are not available. Third and fourth generations are there. Mostly we operate in a newer machines with a micro tip, around 400 to 450 vacuum for chopping, and of course for trenching we use the much lower setting, 100 cc, 150 cc is more than sufficient. And flow rate will also depend upon the stage of the surgery. That means when you're doing a trenching, the parameters will be much lower. Usually 24 cc flow rate, 100 vacuum. But when you are doing a chopping, particularly when you're chopping, you need a very good hole for chopping. And when you are doing aspiration, probably you need more followability. That means if you are chopping all the fragments before, at that time there is no chance of PCR because the capsular furnaces are full with the nuclear material. So even if you suck something, the PCR will not happen. So at a chopping, you can keep the vacuum high. Once the pieces are chopped, you brought them into the central piece. Actually need a better followability than the holding power. So at that time, we want to decrease, if you are getting a surge, you can lower the vacuum but keep the flow rate same. Now we know that if there was no surge, everybody would have been an excellent surgeon without any problem. So what is surge is the sudden withdrawal of the fluid from the anterior chamber. Surge depends upon the compliance and hysteresis of a system. So compliance is the property of the tubing to collapse or deform under pressure. So if the tubing collapses, it is not absolutely proportionate to the vacuum setting because 100 cc it will collapse much more. 200 it won't be that much, not proportionate. Will depend upon the lumen size, more with the larger size, more with the higher vacuum, and the thickness of the tubing. If the tubing is very hard, it won't collapse. So now earlier on we used to use silicone tubing which we used to autoclave, and they had a very soft texture, they used to collapse much more. Now with the disposable system, the tubings are much more harder, and with a narrow bore they do not collapse so much. And the hysteresis is the speed with which the collapsed tube regains its normal shape. If it comes fast, it will suck more from the anterior chamber. But if it comes slowly back to its normal shape, so it won't suck that much fluid. So with this, the present tubings which we are using in a disposable system have got a very good hysteresis and very good compliance, that there is very little surge over there. So this is how this works, that this, as long as this is rotating, there is no collapse, there is no surge. When the piece comes onto this tip and vacuum is built up, then this collapses. As soon as this piece gets sucked in, this tubing comes back to the normal shape, and then this withdraws little bit of fluid from the anterior chamber. This is what causes surge. So depending upon how much it was blocked over there, and if we can raise your foot pedal, like when you deaccelerate the car, once you know that you have reached your destination, you deaccelerate beforehand. So if you can imagine that piece is going to get sucked now, if you, before it gets sucked down, if you can lower the settings, I mean lift your foot slightly up, probably the surge will be much less. So that depends upon your vigilance. If you keep on pressing the full pedal while it is getting sucked, you will have a much higher surge. And because the tubing was collapsible, now there are many machines have got a cassettes, and these cassettes don't collapse and the tubings are hard, so surge is much less. And all the machines have got a defense system, what we call as a venting. Venting is nothing when there is another alternate channel of fluid which is being supplied. So whenever the fluid, this tip is occluded, the vacuum is built up, this is closed. As soon as this gets sucked, this valve opens up over here. Instead of fluid being withdrawn from air, some of the fluid will be supplied from the venting. So this, all the machines have got a venting, so the surge control has become better. So with this we come to the end, and we'll go for the discussion.
Thank you, Dr. Lal. That's always a wonderful talk, though I've been with you for many years when we started all these concepts. And I think they're still relevant no matter how much the machines advance. We still must know our basics to be able to utilize the machine. I'd just like to ask you,
if the audiences have got any questions, they can stand up there and can ask the question. We'll be more than happy to answer. Yeah.
Hello. Good afternoon, sir. It was an excellent talk. I just had one question. I wanted to ask, you were telling us about the burst mode, pulse mode. So now, given the newer machines that have only with torsional Phaco, which is more effective than longitudinal, so do you use pulse and burst mode even on torsional Phaco, or do you use it only on longitudinal machines?
So, the pulse mode, of course, when once there is a the oscillations, we don't need to use the pulse mode per se. But there are still occasions when your tip gets occluded and it's not coming. You do give one short pulse to let you get past that. Burst mode, I don't use personally, but I think burst mode still has a role in the very hard cataracts when you want to just bury into it and hold when using the direct chop. I think there is still a role for burst mode. But yes, the newer machines have made it a lot easier. You still have to be aware of the various modes, that if you get stuck, you know that there is this thing that I can also do.
And actually very hard cataracts, probably torsional energy itself alone is not sufficient. And the that is Alcon machine. And in ellipse mode, in Johnson and Johnson, of course, you use all those parameters. It's only in the Alcon machine where there is a transversal, but I don't think it really cuts very hard cataracts.
Okay, thank you, sir.
How do you manage cases with very small pupils?
Very
Small pupil, very small pupil.
see whenever the hello, yeah, whenever the pupil is small and the fluid which goes into the center and then tries to push the iris out of the womb. So when we talk of the only phaco then we need to do what we call as a hypovolumic phacoemulsification. That means your bottle height should be low so that the less of the fluid is pushing the iris outside the incision, and your suction power should also be low. You want to, because if your bottle height is low, 60 centimeter, you can't have a vacuum of say 400, 500. So this is a hypovolumic phaco. This is one so as the para phaco settings are concerned. But these settings, when you are doing a chopping, because the first piece removal is very, very essential in these cases. So I will usually keep removal of the first piece or the chopping. I'll keep the full settings. Once I chop the first piece, I know that now I've got a good control and I'll be able to take out the pieces. Then I will lower down the parameter.
And I think we should also use the hooks and the rings, especially when you're starting out floppy iris. Always make it comfortable for yourself.
So the most important is that if the pupil size is say 5 millimeter or more, and the iris is not so floppy. One is that there are two types of small pupil. One is the rigid one, which does not flutter, and the another is which just keeps on fluttering when you do the fluid over there. The fluttering one will have a more chances of prolapse. But if it is rigid because of the ace, otherwise there is no issue but form, it won't flutter, it won't come out. So if it is around 5 millimeter, it's perfectly all right. You can perform the surgery. And important, so the closer your incision will be inner incision, that means not the outer. Closer to the limbus, there will be more chances of iris prolapse. That means your incision, if it is little longer and away from the limbus, there will be much less chances of iris prolapse. But if you feel that it is not possible to manage without putting the hooks and rings, then you have got to use them.
So how do you, the surge, the last thing that you were talking about, I think surge always is a very big problem for those starting. So how do we decrease this surge, especially, when towards the end of the surgery, or when we've taken out most of the nucleus? Should we be decreasing the parameters or doing anything like that, or just go with the same parameters?
I think as long as there is a nucleus in the capsular cornices, the chances of posterior capsule coming forward is much less because something is holding back. So once you have taken out the last piece from the nuclear furnaces, that means there's nothing which is holding back the posterior capsule. Then there are chances that as soon as the surge comes, the posterior capsule may come forward. And this becomes very, very important. We are operating a very hard nucleus. Because of the large size of the nucleus, the capsule becomes very floppy or in this situation. So it becomes very, very important to lower down the parameter when you are removing the last fragment. And also because this flow rate what you set is for is the BSSR ringers, but it is not for the thick material. So that means we put on a viscoelastic, though your settings are same, but it won't get sucked that much. So you can effectively reduce the flow rate by putting in a viscoelastic and pushing the capsule back.
And so especially in patients with zonular dialysis, let's say, if the rhexis is not regular and central, do you think the chopping techniques would differ and matter?
If zonular dialysis mein, if the rhexis is not central, would you change your chopping technique? Or would you change your surgical technique?
So whenever we are talking of jonular dialysis, we need to understand that there are two types of jonular weakness. One which is a traumatic. That means whatever jonules have been damaged, they have been damaged, but all others are holding on very strongly. Another is age-related, or you can call it jonulopathy, where the jonules per se are weak. And if the jonular dialysis is associated with the weak, aged person, then it's far more risky as compared to the traumatic where the capsule is not shaking. So whenever there is a jonular dialysis, if it is more than say 3 clock hour, it must be supported by the capsular hook. If the capsular hooks are not there, you can use the iris hook, but capsular hooks and iris hook, there is a basic difference. The capsular hook have got a longer arm. They compress at the equator of the capsule. They do not press at the edge of the capsule. So they are longer. While the iris hook will hold on to the edge of the capsule. So if you have a capsular hook, that is better, is more than 3 o'clock. And again, whenever in doubt and these situations, there should be hypovolumic phacoemulsification. And before, of course, you do the phacoemulsification, you need to ensure that there is no vitreous in the AC.
And
What about the ring? What is your threshold for putting in a capsular tension ring? How many clock hours?
See, normally if it is more than 4 clock hours, I think you need to put the CTR. And now CTR is actually very simple to insert. So any patient, even when I operate a hard cataract where the capsule is little floppy, I put on a CTR because I don't want post-op decentration. Even when you are doing IA, you see the entire capsule is fluttering, I'll put on a CTR. So CTR gives a very good strength. So this is a good idea to put on a CTR. It's better to put on a CTR than not to put it, whatever may be the clock hour. But if you feel that the lens may not center well, and even if you have put on a lens, if you feel the lens is not centering well, there is no harm in putting in a CTR after putting the lens. So you can put the CTR afterwards also, there is no problem.
Just to finish this topic of irregular rhexis, so I think the hydro procedures like hydration of the nucleus and the cataract also matters while we are doing it. Would you like to throw some light on it?
Hydro procedures
Yes.
in jonular dialysis.
Yes, with irregular rhexis. Because usually in zonular dialysis cases, we get irregular rhexis, right?
See, when you are doing a rhexis in jonular dialysis, you need to understand that the rhexis is centered onto the capsule, not to the center of the cornea. So that means you have got to leave approximately 2 millimeter of rim on the side of the jonular dialysis. Because if the capsule is say lens size is 10 millimeter, you want 5 millimeter rhexis. So 2 to 3 millimeter, that side is to be left. And if the jonule, I mean it is a traumatic and fibrous, then rhexis becomes irregular. But some amount of hydrodissection is definitely required because we do not want to give extra stress to the jonules. So it's better to do some amount of hydrodissection, but it should be gentle. There is absolutely no problem.
I think in the very hard diabetic cataracts, there any special techniques for these kind of hard cataracts where they're very sticky and difficult to remove any?
Yeah. See, whenever you are using operating a say grade 5 cataract, at that time you should not use your micro tip at all. It should be a regular big bore tip, as I already explained, because you really want to hold it very strongly. So chopping is very, very difficult if your grip is not strong. So if you hold it strongly, then you will be able to chop it. So they use the regular tip, and my initial, you can go on to the my YouTube channel and see how to operate a hard cataract. So my initial settings are to make a good wide trench so that you can split it very easily. And after splitting it, I'll do the chopping at a 600 vacuum with a regular tip. And first half of the nucleus, usually I'll remove at a very high vacuum. When I come to the second half, I'll go to the 500. When I come to the last fragment, I'll go to 400 and may inject the viscoelastic. And another important point is when you come to the last fragment removal, remove your chopper from the side port, because the side port also keeps on leaking little bit. Main port you got a silicone tubing which is soft and molds according to the incision, but side port you got a chopper which is hard and it keeps the side port open. So when I am about to remove my last fragment which has come to the tip, just when I held the fragment onto the tip, before giving the energy I have to draw my chopper out of the eye so that there is no leakage at that time when this surge is about to come.
Sir, I have a question. Like many of your patients must be, out of your many patients, they have vitrectomized eyes or they have silicone oil filled eyes. So I would like to know how different it is to operate in these eyes and what all precautions we need to take during these cases. So
I think the if the eye is vitrectomized, the chamber becomes very, very deep. So you need to keep your bottle height low. One, I will not mind that if the incision little shorter, because your tunnel is little longer. When you try to dip it in, you develop a folds onto the cornea. So I'll be a little more scleral with a shorter tunnel and a Kelman tip, low bottle height. So these are the things you need to do for trenching. And once you make a trench, then of course it is easier. And you can also do supracapsular phacoemulsification. If you make little larger rexes, then as soon as you do hydro, sometimes the nucleus just pops up. So if it pops up, I do not try to push it back. I will rather take it out. Straight away, instead of trenching, I'll go into the full setting of 500, 600 and take it out. So silicone oil, of course, keeps on giving the different reflexes and keeps on pushing the capsule up, and we have got to be very, very careful again when you come to the last fragment, because there's chances of your touching the capsule over there. So you can put on a viscoelastic and keep the bottle height over there. It will be more than normal. So keep a good bottle height, keep on injecting the viscoelastic, and you got to sometimes there's a shimmering reflex which keeps on troubling you.
so do you think that putting an infusion cannula pars plana route, say, it helps or it is never needed in these cases, especially vitrectomized eyes, if we put an infusion cannula along with
Pars plana for
sir, for the push, because the depth of the anterior chamber won't allow us to keep our
I
flow
really
preventing.
I have not used it
Yeah,
because these
okay.
machines are
Really
really
good.
very, very good. So maybe as a VR surgeon you can do it far more easily, because
Okay.
for a VR surgeon going through the pars plana is much
Yes,
more comfortable.
bread
They
and
don't
butter.
feel. But the anterior segment surgeon, though it's a very easy procedure, I mean there's hardly anything with the trocar and cannula available,
Yeah.
but some or the other we are not used to using that route. But I don't have a personal experience, but I think it should work well. I don't think it should.
I think in the vitrectomized eyes or in some of the very old patients, because of the low scleral rigidity, the chamber does keep collapsing. So putting in repeated viscoelastic, I think, is a really good way of keeping everything, under control. And one of the tips that I learned from you many years ago was in the high myopes. The moment you went in, it was like आप खाई के अंदर पहुंच गए हो, and you had said make just a little main wound just a little bit leaky. Of course, nowadays with the Centurion and the active Sentry, we don't have to worry about all of that. But I always thought that was a very useful tip.
Yes, I also feel that repeated viscoelastic pushing is not harmful, and we should repeatedly do it in high myopes and especially such eyes. And one more thing which I do is that I don't use a chopper after I have chopped main pieces. I come shift to dialer, and during the last pieces to control pieces, I just hold a dumbbell dialer sometimes, and not a chopper per se, which is safer, I feel.
So if there is any other question from the audience,
So you can come to the mic.
yeah, any suggestion from the audience, anything?
So, in case of
In case of
ट्रेवेक्युलेक्टमी केस में सर क्या ध्यान रखना चाहिए सर, पैरामीटर्स पे और मतलब जो है और पावर पे? क्योंकि ट्रेवेक्युलेक्टमी के जो भी केस होते हैं, एक्टिव ट्रेवेक्युलेक्टमी, तो पैसेज बना हुआ रहता है, ट्रेवी बस्ट भी होने के चांसेस होते हैं अगर बहुत ज़्यादा प्रेशर हो या मतलब लीक।
ट्रेवलिन का पैसेज कभी बस्ट नहीं होता है, सो देयर एब्सोल्युटली नो प्रॉब्लम. So I'm coming to it's never burst. I mean, there may be some fluid may go over there, and whenever I operate a very shallow chamber, I mean, if there is a chamber is shallow, that's poses a problem. First, I'll tell you, whenever I operate a very shallow chamber, suppose chamber depth is less than 2 millimeter, I will not do any hydro procedure. I'll just do the epinuclear plate removal, make a trench, divide it, and if the jonules are strong, like we do in a posterior polar cataract, try to remove some fragment, and if you are able to do it, it's fine. Otherwise, after making the trench, dividing into two, then I'll do a little bit of hydro if required. And by and large, by the time you keep on doing these procedures and trying to suck out epinuclear plate underneath the rhexis, the lens starts rotating. Same way when you are doing the trabeculectomy eyes. So if the chamber is very shallow, only in that cases you have got to take all the precaution of the shallow chamber. But the trabeculectomy is more than 3 months old, you really don't have to do. You can put on a viscoat on that the side of trabeculectomy, which can hold on there for a little longer. So that you can do, and keep on injecting. If you have got any doubts, there's a bleb is swelling up, you can keep on injecting the viscoat on that side. But rest of it will be like a shallow chamber, and there may be a few synecdoche which you need to break for doing a good rhexis. But if the synecdoches are beyond, I mean, that means we can make a 5 millimeter of a rhexis without breaking a synecdoche. I will not break the synecdoche because I don't want them to become floppy. Like in a pseudo exfoliation cases, I do not separate the capsule from the iris. If I is good enough, say 5 millimeter rhexis, I can do 4.5 millimeter. I'll rather finish off this surgery, because if I separate and try to enlarge the iris becomes floppy. Same in a traumatic cataract also, if I can do the rhexis, because sometimes the traumatic capsule may be sealed by the iris itself, it may be sealing by the iris. So if I can finish off the surgery and iris is sticking to the lens, I let it be stuck there if I can finish off my surgery. If I feel that it is going to be difficult to complete the surgery, then I will separate the iris.
So book says pre-op mannitol use, any rules?
Mannitol you can use, there is nothing wrong in using mannitol, though I don't use it personally. I mean, if you are doing it under block,
in advanced case,
you do under block, without block.
With block.
So if you are giving it under block, see, the lowering of the IOP by mannitol has got no value, okay? Because when you open a chamber, the IOP immediately goes down. So when you give a mannitol, you are not giving it for the lowering the intraocular pressure. You are giving it for decreasing the vitreous volume. Okay. So mannitol lowers the vitreous volume by 7%. But if you do the massage of the eye, it can lower the vitreous volume by 40%. So that means whatever you are trying to achieve, by the mannitol, just 5-10 minutes of leaving it or doing a gentle massage, you can achieve the same effect.
In advanced glaucoma case.
uh, Advanced, because I do all surgeries topical. So, uh, in fact, I do trabeculectomy also under topical with the Phaco trabeculectomy. And only thing what I do is when I'm doing Phaco trabeculectomy under topical, I'll give 0.1 ml Gilocaine at the site of trabeculectomy, because when you are cauterizing, so that time there is a little bit of pain. The rest of the surgery is painless. In advanced glaucoma cases, I personally feel the washout is because of the block. It is not because of the trabeculectomy. So most of the glaucoma surgeons are scared to operate tubular field patients because they fear the wash out. I personally feel the washout is because you give the Jalocan with Adaline, you increase so much of pressure behind the optic nerve. So I think these patients should be definitely taken up for the topical Phaco or under GA. I will not really recommend giving a block. I mean, if you have to give a block, then give subtenance. Just subconjunctival block little bit is good enough. So don't have to really go for a full block in cases of a very narrow field.
I think you can give Dimox post-op to cover the post-op spike that might happen if there's visco left in. So the Dimox has more of a role post-op, I think, rather than pre-op.
नहीं मैम, पोस्ट आप में तो प्रेशर लो ही रहता है, 1-2 दिन तक तो लो रहता है, उसके बाद ना स्पाइक होता है.
कभी भी हो, मतलब व्हाट एवर इट इज. सो ट्यूबुलर फील्ड में ब्लॉक लगाना मेरे हिसाब से तो ठीक नहीं है.
ओके सर, थैंक यू सर.
Any other question from the audience? And so we basically, whenever you're operating a softer cataract, you got to keep your settings lower. When you're operating a harder cataract, you got to keep your settings high. And same, all settings will depend upon the density of the cataract. Also, the what is the, if you see when we're operating, there are 3-4 things. How is the cornea? That means if the endothelial cell count is low, you are operating Fox, you got to coat it with coat. You would like to have a slow motion Phaco, not damaging, not giving any energy closer to the cornea. If there is a corneal opacity, you are not able to see well, you got to go slow. Chamber depth is shallow, you got to go slow. If there is a jonlopathy, if there is a PCR, if there is a small pupil, if there is a floppy iris, so in all those cases, your Phaco has to be slowed down. When you are on a bumpy ride, you have to go slow. If the road is absolutely smooth, then you can go really fast. And depending upon your experience and depending upon your machine. Thank you, Gaurav.
Sir, I have a last question related to Phaco technique maybe. So we used to operate under RL first and then BSS came into view. So which solution you feel is better? RL or BSS?
Blade.
Sir, we used
Yes,
to
sir.
operate with RL first.
I have been using ringers lactate for whole of my life. Only for last 1 month I have changed. And I thought ringers lactate is as good as BSS because I had no experience. Because the last month I started getting little more inflammation than usual in my post-op cases. So I changed everything. Whatever was there, to viscoelastic, to the intracameral medications, to the fluid, and everything I changed from the top to the bottom. Even the intracameral antibiotic, what I was doing, I changed everything. So since last month, I have shifted to the antasol, and I'm quite happy with that. It's okay, but I think it should not make much of a difference. But I started had 2 cases of TAS, so I didn't know whether it is viscoelastic. It unnecessarily gives you so much of attention whether it's an infection or a TAS. So I thought, let me change everything. So maybe just few days back we used the sodium harnate supplied by, I think, Jivra, by the name of Gynate. And again, in those patients, there were little more cells. So I think I could not analyze all my patients. Maybe wherever we used that Gynate, that was the culprit, not the ringers lactate. So you can use any one of them actually. But we have got to be careful. If according to your surgery, the cells and inflammations are more, you got to be little, try to analyze what is going wrong. Okay, whether the installation is not good, or the air in the OT is not good. So we try to analyze that.
Sir, what can we do other than choosing the correct IOL or the different IOL? What can we do during surgery to prevent PCO formation? Posterior capsular opacification, PCO formation.
See, whenever we talk about PCO, basically good cortical cleanup is essential, particularly where your optics part. I mean, if it is in the equator, little bit is left, it causes not so much of a problem. But there's something under the optics when you are closing it that may pose problem. And the perfect rhexis is the another thing. Uh, that's the 2 points. Good cortical cleanup underneath the optics. That means 6, 7 millimeter, 8 millimeters, and the good cover of the optic is all around, so that it gets compressed. What we call as a capsular wrap syndrome. The lens is totally wrapped into the capsule, and the sharpness of the posterior surface of the lens will not allow the cells to migrate underneath the capsule.
So, do you feel scraping of the undersurface of the anterior capsule, whatever is left? So,
That really not. I used to do very aggressive cleaning, but actually it doesn't make much of a difference.
I think
Something is visible, you can do it otherwise.
like cases of uveitis or traumatic, where you're already anticipating some excess inflammation there, it should be done. Okay. All right, so no more questions. Then thank you very much, sir, for sharing these pearls of phaco and all your experience with us. And thanks to the audience for being here with us.
Okay, thank you.